Hi, my name's Sarah Finocchario Kessler, and I work with Global Health Innovations. It's an NGO focused at bringing technological innovations to improve health outcomes. I work as sort of a research director or advisor there. I also work at the University of Kansas Medical Center as a faculty in family medicine there. And I was here today to talk about the HIV infant tracking system. So it's an online intervention that we developed with our colleagues in Kenya to try to improve early infant diagnosis outcomes. And with this system, its primary goals are to try to improve communication between key stakeholders in early infant diagnosis. So when we talk about those key stakeholders, we're talking about first and foremost the mother-infant pair, also the EID provider at the health facility level, and then the lab technician working at the laboratory. And because for infants we can't do point-of-care testing yet, we have to take a dried blood spot sample, and that sample has to be sent to the laboratory for PCR testing. And the current standard of care, there's a lot of breakdown that can occur between that transport of sample back and forth. It can result in several extensive delays that prolong an infant's ability to be started on treatment early. And so when we look at developing the HIT system with our partners in Kenya, when we look at sort of our two primary outcomes that we'd like to change, it's to, one, try to make sure that we're getting all of our HIV positive infants who are diagnosed through EID, get them connected to antiretroviral therapy as soon as possible. And then secondly, EID is sort of famous for having really poor retention. Ideally, we want to retain these babies in care until they're 18 months of age. And so that's our second primary goal, is to try to increase and improve EID retention so that we're testing these infants at 6 weeks, hopefully getting back an HIV negative test result, getting them back in the office at 9 months, and back again for final retesting at 18 months. So to do that, we really are engaging the mothers and helping them feel that we are being responsive to their needs. Part of what we do also through the HIT system is to send an automatic text message to the mom's cell phone. A majority of our moms in Kenya utilize cell phones, and this allows a way to communicate with them when we need them to return with the baby to either receive test results or to follow up on additional care that's needed for the infant. So the idea from the program was really driven by clinical need. So the founder of Global Health Innovations is Mr. Brad Gauntney. He's a clinical HIV pediatric provider and has worked in low-resource settings for several years. And so through his work as a clinician and then working with program planners in EID, also health administrators at the laboratory, he was able to really get extensive experience to get a very good feel of what are the barriers to providing effective early infant diagnosis. So through working together with partners in Kenya, we developed, we knew well what the barriers were. But then we looked at how can we use technology to try to overcome some of these barriers. And so really the HIT system is at the main point, it's a health systems intervention. Tries to overcome a lot of the barriers that exist. And in doing so, it's connecting, again, those stakeholders in EID to improve communication and accountability to each other. So the idea really came from the clinical need and the programmatic need. And then fortunately, we were able to utilize cell phones given that a majority of Kenyans and now close to a majority of Africans are using cell phones. Well, we didn't experience barriers initially working with our partners at the Kenya Medical Research Institute. I like to describe them as sort of the equivalent of like the CDC in the United States. They really help develop and man the laboratories and do a lot of the testing and the research for the country. In fact, they're the largest research institute in East Africa. And they work closely with NASCOP, which is the National STI and AIDS Control Program of Kenya, part of the Ministry of Health. And so we wanted to make sure we were partnering with government partners. And so interestingly, we did meet some resistance, but that was more to other groups who may have been working in a similar area there. But with some communication, we were able to overcome that. Now that we sort of have a proof of concept, we have data from a year of intervention that's able to demonstrate a significant impact. Now we find ourselves at a new point where we can work together with our partners and help decide, what's the best strategy to scale this up, what will be needed for that, and how can we try to go about doing that in a way that will help maintain good quality outcomes, but also scale it up if that is in fact what the government of Kenya wants to do. Yeah, so it was really implemented in the pilot sites as sort of the new standard of care, but women were offered the opportunity to opt out. If they didn't want to have their information entered in the HIT system, or they didn't want to, or they didn't have a cell phone or didn't want to provide that, that was fine. It was an optional. But what we found was less than 1% of the moms chose or wanted to stick with the paper-based system. They wanted to try this new intervention. Now, not all of our moms had cell phones, but there are also some moms who had cell phones that didn't feel comfortable giving us the phone number. And I would estimate that was less than 4%. But we absolutely respect that and understand, concerns that they may have had, particularly if they hadn't disclosed to a partner. Now, when we send the text messages to the mothers, we met with mothers to get a feel of what language we should use, because the text message is sent in Swahili, but we wanted to make sure the message that we used was appropriate and would not risk unintentional disclosure of any of our moms. So they came up with a message of saying, please bring baby to the clinic. And since babies come all the time for immunizations and follow-up care, I felt like this was a safe message to use, and so that's what we've been using in Kenya. Well, at this point, it's really an intervention for early infant diagnosis, and so that sort of has this already predetermined date of 18 months, at the point where we feel like if we test the infant at 18 months, their test is HIV negative, that we can safely conclude that that child is HIV free, because breastfeeding should have ended at that point, and there shouldn't be any other route of transmission to the infant. Now, moving forward, when we look at trying to reduce infant mortality and child mortality under 5 years of age, I'm sure that we could think together of other ways that we could adapt or apply the HIT system to continue, for example, with immunizations and other services and outreach for children. We haven't gone there yet, but I think that's one of the great things about the HIT system is it's an open technology. It's very adaptable. It's just a matter of us thinking of together with our partners of the public health need and modifying the system to address that. Well, I'm glad you raised that point, because actually that's one of the steps we're looking at now. It's fortunately a very small proportion of our infants who are testing positive. So at our sites it ranges from about 3% testing positive at one site to about 11% at another site. But what we want to do is to try to take some lessons learned from other groups that have been using cell phone technology and have found that it's been very effective in adherence, so adhering to HIV medications for adults. We know adhering infant adherence or child adherence to medications is really difficult. The medications don't taste good. It's hard to get children to take, pills or even syrups. So we want to take as an additional step, what we look at is doing some more additional follow-up. So it's one thing to link the infant to antiretroviral therapy and make sure that they've started the therapy, but as you bring a great point, we want to follow up with those mothers and try to help provide additional support and reminding to help with the baby's adherence. Yeah, Global Health Innovations is a 501c3. It's a nonprofit, and really it's a total tribute to Brad Gontney and his fundraising skills. Much of this is privately funded. It's just been small. We operate on a shoestring budget, and it's really been private funding. We are applying for grants, and we're trying to expand opportunities for additional funding that can help us expand the program. Yeah, so we actually also work closely with colleagues in Malawi, and they were asking for us to adapt a version of the HIT system that could work there. The healthcare infrastructure is not quite as advanced as it is in Kenya, and cell phone use is much lower. But what we've looked at doing is still trying to link those key stakeholders in EID that we talked about, the mother, infant, the hospital, and the laboratory. But we're relying much more on community health workers to help us with the follow-up with mothers. It's not as easy as just sending a text message, but we're finding that the network with community healthcare workers and the community healthcare workers can have a cell phone. It still helps facilitate follow-up with the mothers bringing the infants in. So it's a very different model there, and we're very new in the process. It's only been a couple months there. So it's a learning experience for both, but we are adapting it to the needs of the population there. If we can continue to demonstrate the type of impact that we have in Kenya, then we would love to, because we can see that it's making a difference. We hear from the participants involved, from the healthcare providers, from the lab, from the mothers, that this is making a positive difference. So if we can play a small role in improving the quality of care for infants and mothers, then yeah, we would like to expand that. Last slide, I just want to thank our partners in Kenya. I think that they've continued to teach us so much through this process, and those who have been involved. It's a really iterative process. You go in thinking you've got a pretty good idea, but it continues to evolve and improve the more interaction that we have there. So part of why I think it's doing so well is it's so customized to the needs of those who are using it, and for that we really thank all of our participants.